This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Today we come to the final of our 6 sessions on health reform. I want to thank my co-organizer, Janet Kaufman, with whom it's always a pleasure to work. Speakers tonight, the speakers for all the sessions. Last week we had the Masters of the Universe who run the major health institutions in the Bay Area, discuss its impact on them. Today, we conclude looking into the future about how you would know whether or not it's working, in other words, monitoring it. My other task today is to interview Dr. Ruth Brousseau, whom I've only known for 32 years. Ruth is a social psychologist by training from Harvard, but we won't hold that against her. She has had a stellar career running nonprofit organizations, working in philanthropy, the end of which she was the director of evaluation for California Health Wellness Foundation, and has since, for the last half-decade or so, been doing evaluations as the director of health partnerships. In the more extensive bio that's in the handout, you'll see all of the stellar organizations that she has done evaluations for. In order to save what could take up the entire session, I'll just turn it over to her now.
Thank you, Ed, and congratulations to you and Janet for an extremely successful series. This evening, we're going to appropriately look forward with the ACA to talk about what the impacts of health reform are going to be. I don't think I have to make an argument to this audience about the importance of studying impacts. When I thought about this topic, I thought there are some deep ironies here. One of them is that health reform is being evaluated every day in the daily newspapers. There's a minute-by-minute assessment of what's going on. The latest was in this morning's paper with the news about the Republican victory of a Florida congressional seat that was taken to be a referendum on health reform. So it's already evaluated and we're already losing. And we see in the daily count of enrollees and whether benchmarks are being met. We saw it in the cost of emergency care in Oregon. There's a constant bombardment of very short-term measures that, through an evaluative eye, are often measures that are way too short-term, too isolated from a larger context, and too fraught with political steam to really think about them as being evaluation data. The other side of this picture is that there's almost a dearth of information about the information that is available and will be available from scientifically conducted assessments. The one exception that I have seen was an article that caught my eye in the New York Times in February. It was a front-page paper, and it was titled "Evaluation of Health Reform." The entire gist of the article was to take exception with the Center for Innovation, which has been funded by the government to do some types of evaluation of ACA. And the gist of the article was that this was never going to work because they weren't doing randomly assigned experimental design research. So that's the other side of the picture when you look about the dearth of, when you say there's a little bit of information, well, that was very biased and kind of strange information. If you think of evaluative information as being basically a desert, the New York Times picked up on a very small and strange oasis to put in front of the public eye. On a much more optimistic and positive note, within the last couple of weeks, Andy Bindman, who spoke here 2 weeks ago, had a forum in JAMA in which he basically made the rhetorical, or asked the rhetorical question of whether the ACA may be ushering the finest hours of health research, health services research into being. And I think in this dearth of information, we're very lucky to have with us tonight 4 different scholars who will be assuredly at the front lines of this research in the coming years to create the finest hours for health services research. Because you have the long list of their accomplishments in front of you, I'm not going to go through them in depth, but trust me that they are very distinguished. I think you'll trust me on that. And that they're full biographies which give more detail about their research and how it's coming into play in the public sphere and they're also very interesting, so please do read them and go into more depth. But let me talk about the sequence of the speakers, and in so doing, give you a little bit of background. We're going to first start with Marian Mulkey, who is Director of Health Reform and Public Program Initiative at the California Healthcare Foundation. Marian will provide an overview of some frameworks for evaluation that have come to her notice and tell us also what the California Healthcare Foundation, which has long taken a leading role in California in making health data and health information accessible to the public, she'll tell us what her foundation is doing. We'll then turn to Will Dow, who's professor of health economics at Berkeley and head of the Division of Health Policy and Management. Dr. Dow's research focuses on, and he will talk about, health spending in the context of the national economy within the confines of what's happening because of the ACA. Next in line will be Ken Jacobs, who is chair of the Center for Labor Research and Education at Cal. Ken's research focuses on access to health insurance and using health modeling what different effects are among different populations in terms of coverage. He will talk to us about factors for both predicting and evaluating patterns in health insurance coverage. Finally will be Claire Brindis, who, among other distinguished titles, is the director of the Philip Lee Institute for Health Policy Studies here at UCSF. Claire will talk to us on adolescent health and women's health. These are both very important topics on their own right, and they also, for the purposes of this evening, are exemplary of the different types of populations and health issues which will be important to follow in health reform as it unfolds. So I'm going to turn this over to Marian, and there is just one slight disclaimer, which I'm sure that you understand, which is that because health reform is so huge, such an elephant, there are so many facets of it that if we were here for days on end with hundreds of speakers, we wouldn't begin to cover all of the important areas of health reform that will be important to evaluate. So the speakers who are here are taking a broad and important cut into these areas of evaluation, but we don't pretend that we're even beginning to touch the many different dimensions that will be important to follow in the coming years. So, Marion.
Thank you so much. It's a pleasure to be here tonight. I am Marion Mulkey. I've been introduced. That's good. Let's see. Okay, and this is kind of an obligatory description of what the California Healthcare Foundation is. For those of you who don't know us, we're an independent philanthropy based in Oakland and are about 17 years old now and have been working on issues related to the California's healthcare finance and delivery system over that entire period. I, in particular, focus on issues around health insurance coverage, and as was suggested, I think a lot of the remarks tonight are going to be around the central features of the Affordable Care Act that do focus on expanding coverage, dealing with cost and access to care. But as suggested, there are many, many other provisions in the law that could be independently evaluated and monitored if one were so inclined. My topics today, I'm going to talk about national monitoring and evaluation efforts, just very briefly, a quick overview of some of the other efforts that are underway. There are many. I'm going to offer for you a framework for monitoring Californians' coverage, affordability, and access to care in the era of the Affordable Care Act. This is a framework that CHCF has developed, and I'll walk you through. And then finally, I'm going to describe for you some projects that we have underway right now to look at sort of early indications of what's happening in the state under the law. I'll start with just really a very quick landscape scan of some of the other efforts that are underway around the country. The Robert Wood Johnson Foundation has established a data hub where all kinds of data about coverage and access and all manner of health-related indicators are available. It's a terrific resource, easy to navigate, worth looking at it if you're interested in state comparisons and at what's going on nationwide. The Kaiser Family Foundation is known to many of us in the health research community as a terrific go-to resource that, again, is a compendium of data on many, many different topics, state by state and nationally. The Health and Human Services, Federal Health and Human Services Center for Program Evaluation also is reporting and monitoring data on a regular basis about enrollment and many other factors that are important to watch under the Affordable Care Act. Again, another resource from the Robert Wood Johnson Foundation is a set of evaluative activities in partnership with the Urban Institute looking at what is happening on the ground in different states. I should say here, catching a breath, that we included links in your materials to all these documents and can provide more information if needed. And then finally, the American Institutes for Research is a contractor to the Center for Medicare and Medicaid Services to evaluate some of the specific outcomes under the Affordable Care Act. This talks about the survey that they're doing of exchange enrollees. So again, just a very quick skim through a few of the activities that are underway. But there is a lot going on. Many of these things will take some time to play out. And so there will be places to go and things to watch, but it'll be a while before there's a definitive view on any of these issues. So at the California Healthcare Foundation, very soon after the Affordable Care Act passed, it seemed to us that there was probably an opportunity for us as an independent foundation to take sort of the long view, identify what some of the key metrics were to be watching, and to develop a framework for monitoring. And we did that in partnership with an organization, the acronym for which, thank goodness my notes are up here, the State Health Access Data and Assistance Center, which is based at the University of Minnesota, was our partner in developing that framework. And I'll take you through that in the subsequent slides. But this was a very interesting exercise. We intended to look broadly at existing data and then identify gaps in that data that we again, as a state-based foundation might be able to fill. And I'll walk you through what we ended up with. We did take some time in 2011 to vet that framework with a variety of stakeholders, including some of the researchers in this room, and feel like it's a reasonable starting point, though certainly not exhaustive in terms of a way to evaluate what's going on under the law. So this is the framework that we developed ended up really focusing on 3 large domains. Coverage, which is again a central goal of the law to expand coverage and to reduce the number of uninsured. Affordability and comprehensiveness, and then access to care. So I'm not going to walk through every one of these indicators, but in general, what we ended up with was 52, I think, maybe 54 indicators that we think are both relevant and sustainable to report over time. And as I indicated, many of these come from other data sources. So this is going to be best seen as sort of a mashup of data from some of the sources that you'll hear more about later tonight, as opposed to an original data collection exercise. But in a few cases, we are working hard to partner with some of the state entities that have access to some of this data and try and make it comprehensible and reportable for a more general audience. So again, this is more illustrative. I'm not going to walk you through every one of these indicators, but I think you'll see that it covers a reasonable breadth while not getting so far down into the weeds that it's hard to understand. The second domain that we're reporting on is affordability and comprehensiveness of coverage. So this looks at insurance premiums, at the levels of coverage in terms of comprehensiveness, how much cost sharing is being asked from people, what people report as their financial burden, whether people are obtaining subsidies to help them afford coverage. And then finally, the third domain is access to care. And of course, this is, again, the reason that you want more people to have coverage is because you hope and expect that they will have better access to care, cutting across their sources of care, the place that they usually get care, the barriers that they report to receiving care. And then you want to look at the system, too. Are physicians taking new visits? Do people have an opportunity to get timely care? What's happening to safety net providers with this new influx of patients? So we're excited to have developed this framework. We're in the process now of collecting baseline data and expect to report that probably in the late spring, April, May kind of timeline. And again, it'll be a starting point. Some of these indicators won't be reportable yet because the changes haven't occurred, but we think it'll be a good foundation. So that's sort of our big picture, high-level effort at the California Healthcare Foundation. I want to turn now to things that are a little closer to the ground and a little bit more specific about what's happening right now. We have a set of projects underway, and again, for the interest of time, I'm not going to spend a lot of time on any one of these, but it kind of gives you an illustration of where I think some of the interesting things to watch are. And this, I'll add, this is not sort of a formal academic evaluation. This is much more, can we watch and pay attention and ask interesting questions that can maybe give us answers that are relevant to the policymakers and stakeholders who are actually influencing this. The first project under this set of activities is looking at consumer and enrollment counselor experiences in the whole gamut of shopping for, enrolling in coverage under this new set of opportunities through the Affordable Care Act. So we've completed a set of focus groups in 4 different locations around the state, 4 different languages, have results that'll be out in April. That really ask what motivated people to look for new coverage in the first place, what happened when they tried to access it, what are some of the challenges, what are some of the success stories, how can you build on that in the coming year. A second component of this project is to look at the online user experience that people undergo through Covered California. And that project, too, has most of the data collection's been done, and we'll have results, we think, in April. And I should say that the timeline from our perspective is to learn from this current open enrollment period and the current activities in this first year and try to build on it, help stakeholders and the government organizations that are implementing the law learn from this first round and build on it and improve in the future. So this is a project that we're doing with a couple of grantees, GoToMedia, which does online user experience research. Who knew there was such a thing? Target, it turns out, but and Manat Health Solutions, which is a law firm that provides policy guidance. Again, that's the timeline for that component of the project. Okay, this next one is kind of out there, but one of the things that we thought would be interesting in these early days of implementing the Affordable Care Act is to ask what people are saying about the law. And working with an entity called Topsy, which is an analytic engine that captures Twitter, the Twitter feed, and analyzes it, we embarked on sort of an experimental exercise to ask if we could isolate the consumer voice in the Twitterverse regarding the Affordable Care Act. And it was hard, and in the process of doing this, Topsy got bought by Apple, and so we may not be able to do it much longer. But this chart shows you over the period of December through mid-January, what people were saying about affordability under the Affordable Care Act. So the blue lines are people tweeting that coverage is affordable or more affordable than it used to be, and the green is people saying, nope, less affordable or not affordable at all. And what you see, which is generally good news for proponents of the law, is that there's more action out there saying, yeah, it's affordable, it's a good thing in terms of its cost, compared to people who are, of course, some people are also saying the opposite. So that's just a little illustration of something that we thought was interesting to watch and that could be captured literally in real time. And then finally, we have a work that's really a project just underway, looking at consumers' experiences as they first begin to access care under the new coverage that they've obtained through the law. So again, we have some qualitative research underway looking at both what consumers say and what providers and the administrative staff at healthcare primary care settings say about consumer expectations, about their use of care, their ability to be referred to specialists if they need it, or in the case of the doctors, to refer them to specialists. So we think there are lessons there to be learned about the way that the products are designed, the way the networks are established, and the expectations that consumers have about what kind of care they need and how they're going to access it. So, whirlwind view of some of the things that we have underway. I was just going to conclude by offering a couple of kind of high-level observations. So as I suggested, though did not describe comprehensively, there's a lot going on. There are a lot of people investing a lot of time and energy in paying attention to what's happening under the law, and much of that work is terrific and will doubtless teach us all kinds of things over coming years. But I would argue, and I think probably I would find a sympathetic audience here, it's pretty hard to isolate what's happening because of the Affordable Care Act from all the things that are happening more broadly in healthcare, finance, delivery, and coverage and access. And so, of course, what you want as any good evaluator is to think, what are the important outcomes that we want to pay attention to? What matters? What was going on with those things before the law passed? What's going on with them now? Is there a reason to think that there are elements of the law, either as written or as implemented, that were really the factors that made the difference? And if so, could they be changed? And then, again, much more important to think broadly, what's happened under the law? What is it that we're trying to advance? Are we on the right track, or is there a need for correction? Than to think specifically, in my mind anyway, about any particular component of the Affordable Care Act.
Next, we'll hear from Will Dow. Will is professor of health economics at Berkeley and head of the Division of Health Policy and Management.
Terrific. Thank you so much for inviting me. It's wonderful to hear that overview, Marianne, of all of the activities was fast. Of all of the activities that are going on in terms of the monitoring space around insurance and sort of access to care. That's obviously one of the really most important goals of the ACA and health reform. I was asked to speak today about a complementary set of issues, and that is really around financing issues associated with the ACA. And this is, again, something that, as sort of Marion alluded to at the end, there's going to be both a monitoring component where we want to understand how financing issues are changing over time, and there's also an evaluation component where we would like to understand particular components of the ACA and how those may be having sort of causal impacts on different aspects of financing. So when we think about financing, there are lots of different dimensions of this that we can think about, and I'll just be touching on a few. First, we can think about total national health expenditures and how ACA and health reform seems to be affecting those. We can think about government budgets, so we could think about this at the federal, and state, sort of county, so local level. I'll just say a few remarks about this at the federal level. We could also think about this from the perspective of the individual, the individual person who may be getting insurance for the first time or who may be changing their insurance policy in terms of their out-of-pocket payments. And we can think about it in terms of sort of premiums as paid by individuals and as paid by their employers, for example, and who is sort of bearing the cost of these. So let me touch on a few of these different dimensions over the next few minutes. So just to remind everybody what these sort of long-term trends look like in health expenditures, of course, back in sort of 1960, before we passed Medicare and Medicaid legislation, we spent about 5% of GDP on healthcare, and we've gone up and up and up. And one constituency within healthcare reform really wanted to see health reforms that were going to affect the growth rates. And of course, those supporters of the ACA want to be able to say that the ACA is affecting growth rates in some way of tempering them. And so if we look at growth rates over sort of a shorter time period, at the very right hand of this graph in national health expenditures, the top line, we see that it looks like in 2010 and 2011, the growth rate of health spending seemed to have tapered off. So why is that? And how would we really be able to convince ourselves what was causing that, what that had to do with the ACA? Okay, so the White House recently has been, if you look at the sort of economic report of the president and some of their sort of recent communications, they've pointed to some of the important features of the ACA that don't have anything to do with insurance coverage, since most of the insurance coverage aspects of the ACA haven't kicked in yet. But they point to other parts of health reforms, such as encouraging hospitals to reduce readmissions, other things like that, that are changes in the delivery sector. And they are arguing that the ACA and health reform in general has been important in trying to lower this growth rate. Well, if we also sort of line up this sort of change in growth rate with the recession, and we look at this national health care expenditures as percent of GDP growth, well, there's some individuals who have argued that the depth of the recession in coming out of 2008, 9, 10, 11 seems to have slowed down individuals' demand for health care and their ability to pay for health care, and that this is only a very temporary blip in healthcare spending, and that we are going to then see healthcare spending taking off again fairly soon. And so there have been a number of studies trying to compare different recessionary periods to healthcare spending and project based on this information what's happening. So we're going to see many studies like this come out into the public domain arguing that, well, no, it has something to do with the recession, nothing to do with the ACA. Well, here's results from a study that was published very recently in the journal sort of Health Affairs that attempted to take into account different factors that will affect healthcare spending and break it down. And if you look in at the sort of right-hand set of bars in each set here, you can see that in 2012, as in many of the other years, it is medical prices and medical price growth which is accounting for much of the change in healthcare spending. And if we look at how spending has changed over time, a lot of these changes, it's a decreased medical price growth. And so that suggests that if we really want to hone in on what are the implications of different dimensions of the ACA, we might want to try to understand in particular what's happening to medical price growth. Okay, so something around readmissions may, in the long run, be very important, but in this very short-term time period, it looks like it's going to be price growth. So decomposing these different aspects of healthcare expenditures is going to be quite important. Now, and as part of another study that was published in Health Affairs this past year, they tried to simulate or tried to estimate what spending levels would be for national health expenditures with and without the Affordable Care Act. And if you compare the top and bottom bar in each one of these, you'll see that they were estimating that the Affordable Care Act is actually going to increase spending in each one of these areas. And if you look at these bottom sets of bars, well, they suggest that, well, health insurance costs and administrative costs of health insurance are in particular going to be growing very fast. Okay. So again, that sort of helps us hone in on where we might be wanting to look at what's happening to expenditures. Now, of course, it's very important to note that in the very top of this pie, this indicates the breakdown of national health spending by different categories. Insurance administration only accounts for a few percent of total health spending. And so even though spending as a percentage may go up very fast for insurance administration, we're going to have to think carefully about how important that is in the overall pie. Because I can guarantee you that we are going to see a whole set of different headlines coming out from different studies that have sort of different agendas potentially, and which are going to be promoted by different groups, and it's going to be essential that we dig in to those details and not just sort of look at these headlines. Okay, so I mean, it's wonderful to see all you here as sort of educated consumers, and I would encourage you to always sort of dig into those source materials, because some of the journalists do a terrific job at this, and some of them don't. And often the headline writers have the hardest time putting the nuance into the headlines. Okay, so here is another sort of graph trying to project out over the next, through 2020 or so, what national health expenditures would look like in the absence of the ACA and with the ACA. And we can see that with the ACA, we're going to see a bump up in spending right in 2014 or so in the annual growth rate, as there's a whole set of people who will become newly insured. And then, depending on the model that you're using, you might estimate that spending is going to look very similar in the out years with and without the ACA in terms of the growth rate in spending. Okay, so in a study like this, what's going to be particularly important is what are they assuming about what the future growth rate and spending is going to be. So David Cutler, who is someone who's sort of worked with the administration on some of the health reforms and has been one of the voices arguing that health reform is likely to change growth rates, he has done simulations where he takes different types of growth rates and projected out health spending through 2021. And if you look at the very top line here, this is the CMS, the Centers for Medicare, Medicaid and Medicare, so the federal government actuaries' forecast of projected health spending going up fairly rapidly. And David Cutler has suggested, well, what if healthcare spending changes are actually, the recent decline in growth rates are permanent? Well, they're going to be much lower growth rate over time, and the difference in per capita healthcare spending could be 14% lower than what it would have been otherwise. Okay, so again, very different assumptions, and I encourage you to sort of dig into what some of those assumptions are going to be. Now, if we think again about what was driving some of the recent changes in healthcare spending from the earlier graph, it suggested, well, prices. So a decrease in the growth rate of prices was very important. When we think about price changes, those are often sort of one-time level changes. right? You can't sustain growth, you can't sustain very easily a decrease in the growth rate of prices year over year over year. So with certain efficiency gains, you can try to squeeze down the growth rates temporarily and bring down the level of spending, but then the rate of growth of spending is going to be much harder to do. So if we really want to try to understand in the out years what's happening to national health expenditures, we're probably going to have to be looking at delivery reforms. Okay. Are different incentives for hospitals to try to reduce spending through accountable care organizations, et cetera? How are those actually affecting spending? And that's going to take very sort of detailed studies comparing different hospitals that are undergoing different incentives and making different changes and understanding what is happening to spending in those kinds of hospitals. And so go on. If we think about then federal government spending, if we look at the Congressional Budget Office's estimates of the cost and financing of the ACA over a 10-year window, this is about $1.7 trillion. Within that same legislation, there's about $1.8 trillion in revenue associated with the ACA. And we've heard many different headlines over the last few years about, is the ACA actually going to reduce government spending or increase government spending? Well, it was originally scored, this is the 2012 version of the scoring, it looked like it was going to reduce government spending. The Congressional Budget Office doesn't necessarily go back retrospectively and give us some formal analysis of, well, what actually happened. So again, we're going to have competing narratives where different groups are going to go in and look at, well, how much revenue did we actually take in terms of penalties? How much revenue did we actually take in terms of new taxes? How much did we cut different providers' costs? Right? So this is going to be tracking actually the federal government expenditures and trying to understand on net what was happening with the ACA. I would agree with Marion in the case of this, it's probably not as important to understand exactly what the total effect was, because future recessions or other factors are really going to change this, but we are going to see sort of many competing narratives in this domain. Okay, well, where's a lot of that money going? So much of the money that the federal government is spending is actually being transferred to individuals who are going to be getting new care. And so just to tie back to some of the other presentations today, sort of Medicaid coverage is going to be one of the most dramatic changes for many individuals who don't have any insurance today. Many of them are going to be transitioning onto Medicaid. So these results here are from a recent study in Oregon in which a set of individuals were given access to Medicaid, and they were actually randomized in terms of their access to Medicaid when Medicaid was expanding there. And we see that those individuals who would have been eligible for Medicaid, but when they were randomized, they didn't get access to it, we see that 5 to 6% of them had catastrophic medical costs in the following period. Those individuals who were randomized to Medicaid, about 1% had catastrophic medical costs. So this is sort of a big effect on individuals' lives when you have these sort of catastrophic medical costs that are sending you into medical debt, et cetera. So what we're going to see is not actual formal randomization, but we're going to see many attempts by researchers to find groups in states such as California that are expanding Medicaid, compare them to groups in states, maybe Texas or other states, and try to adjust for other differences between what, the experience of these individuals, and try to estimate how much better off those individuals are with Medicaid than without. And of course, that's going to be important to understand as further states are evaluating their potential policy changes around Medicaid. So this is going to be, I think, a sort of fascinating area of research going forward. So another set of studies that we can, in terms of financing, is going to be the premiums that individuals are paying. So if we look at premium growth rates over time, they've been very dramatic. And employers have been some of the strongest constituencies in some cases for wanting to see some type of healthcare reform to try to slow down that growth rate in premiums, although they've been very concerned about some aspects of healthcare reform, such as sort of employer mandates. And so what we really want to try to understand very carefully is, so what are sort of the competing effects of these on insurance premiums that employers are paying and the insurance premiums that individuals are paying. So let me give you an example of the style of a study that we're likely to see going forward. And this is some work that I did with colleagues at Berkeley looking at Healthy San Francisco. So when Healthy San Francisco came in 2008, we saw employers with more than 20 employees were required to spend minimum amount on health spending for each of their employees. And we saw this law affected San Francisco. It didn't affect surrounding areas outside of San Francisco, and it, of course, didn't affect other cities and other places. So what we did is a survey of employers, and we asked them about the total premiums that they were paying, the premiums that the employer themselves were paying, and what they were asking their employees to pay. And in that case, one of the very interesting things, if you look at the set of bars on the right, is that the increase in premiums over time, before and after 2008, was much lower in terms of what employees were being asked to pay than when compared to other employers outside of San Francisco and sort of surrounding counties. So we see very clear evidence here that the requirements that employers take up a certain amount of the spending led the employers to take on more of the spending, and less of that premium growth rate was being sort of passed on to the employees. So we're going to see, again, this kind of design when we observe that some sets of employers are seeing big changes in the insurance that they're offering their employees. And there are lots of employers that are going to see relatively small changes because they've already have very high coverage rates among their employees. So we're going to see different designs such as this, where we're looking sort of before and after employer mandates come in, before and after different changes that are affecting employees, and we'll be able to compare them. Now, in the case of Healthy San Francisco, one of the very contentious issues was whether or not this legislation that was requiring employers to pay additional amounts towards their employees' health care was going to be job killing in some sense. And in this case, what we did was compare San Francisco employment to other cities around the country over this time period. And if you look at sort of the upper left, you can see that the trend of employment in San Francisco compared to other major cities didn't show any evidence at all that there was a decrease in employment. Okay, so again, we're going to see all sorts of creative designs by individuals coming up with quasi-experiments of creating control groups of individuals and firms that have been affected by the ACA and not affected by the ACA. And this is a lot of the evaluation work that's going to unroll over the next few years that's going to allow us to have more understanding of what the more plausibly causal effects are of the different components of the ACA, moving beyond the sort of very important monitoring effects. So I am going to stop there, and thank you. I look forward to the Q&A.
Thank you, Will. That was a great series of items that we should be looking forward to and ways of thinking about what we're going to be seeing in terms of data for the next couple of years. Next, we're going to have Ken Jacobs, who's chair of the Center for Labor Research and Education at UC Berkeley. Thanks, Ken.
Thank you, and I want to thank Janet Kaufman and Ed Yellen for organizing this and inviting us here tonight. I'm going to talk about work that we've been doing predicting changes in coverage in California with the Affordable Care Act, and that's always an interesting exercise because people will know whether or not we were right or wrong. And so I'm going to lay out sort of a little bit of our thinking in doing that, and then talk about how we should think about monitoring those changes, understanding those changes, both in terms of health coverage offerings and getting back to where some of the things Will was looking at in the end around the labor market and what are some of the big debates in the labor market. So we, working with the UCLA Center for Health Policy Research and support from the California Endowment, created a model called the California Simulation of Insurance Market Model, CalSIM. And the point of the model was to be able to look at how certain policy changes would affect the types of coverage that people would have in the state of California. And we did this also with support from and for Covered California and doing the modeling for them. And the basic notion here is to predict the impacts of the policy changes both on employer decisions to offer coverage and on individuals' decisions to take up that coverage. Now, I have to say, in doing so, we drew on the economics literature, looking at the elasticity of demand for health coverage by individuals at different income levels. As your price of coverage changes, how does that affect your people's decision to take that coverage? And we treat this all as a rational economic exercise on both parts. We look at employers, treat them essentially as purchasing agents for their workers, right? An employer could give compensation in money in cash. They could give compensation in health care benefits. They're making a decision to do what they're doing because of the way the market is structured today. And under what conditions would they decide it makes more sense to not offer coverage and maybe pay people more in terms of a cash wage, or we should add more coverage where we're not currently offering it. And so we look at how the policies change those things. Of course, we don't factor in things like the Koch brothers doing ads in states telling people not to enroll, and we assume that in the end all that washes out. We may be right, we may be wrong about various assumptions. So the kinds of questions that we look at here is how, again, we're trying to look at how is insurance coverage changing? What's the share of people with job-based coverage? We can look at reasons that would go up and reasons that would go down, right? So we now have an individual mandate, so there's going to be a greater demand for coverage. So some employers may then offer coverage who were not previously offering it. And on the other hand, we now have options outside of the job-based coverage. We have subsidies for lower wage workers. And so some employers may say, our employees would actually be better off and come out ahead if they were to get coverage through one of the exchanges, through Medicaid, and we can just give them a little bit more money. So that we look at how do we see changes in Medi-Cal, who will go into Covered California, what are their demographics, what's the individual market look like, if the people who are not receiving subsidies. And a good part of this also for Covered California was the demographic analysis, right? They need to do their outreach, they need to do their enrollment. Who are we looking at in that market? Receiving subsidies, and very importantly, who's going to remain uninsured. And we did a lot of work that was funded by the Blue Shield of California Foundation looking at that specific question going forward, and I'll get into that a little bit in a minute. So we also are testing policy questions, right? How important is the individual penalty? If you get rid of it, what does it do? How important is the employer penalty? What's the risk mix going to be? And what does that do for price? And again, what does that mean for dropping? So part of this also is the point of the model is to be able to test these policy solutions. So what were our base predictions? We predicted a small decline in job-based coverage, about 3 percentage points. That puts us pretty similar to where the CBO is on that. I have to say we've been doing some revised work and expect that to be a little bit less, only because going into the recession there was a greater drop in job-based coverage for low-wage workers, and it may be that we've already experienced some of this before the ACA went into effect. We had projections on Medi-Cal. These are 2019 projections, and it's actually an important point here. The reason we do projections for 2019, we have 2014 projections, which you can look at. They're online, so you can test us a little earlier. But the reason we do 2019 is it takes a while for all of this to roll in. And I think it's just important as we're thinking about these things overall and doing evaluation in a 24-hour news cycle when everybody wants to know who's winning and losing. There's a lot we won't know for a long period of time. And so we sort of expect kind of the outline, looking at what's happened at other sorts of health reforms, is you're really looking at a 3 to 5 year roll-in period where you'd expect all the change to be made. And so trying to do very quick evaluations may be edifying, but is often unenlightening. The other big thing here, of course, is looking at we are projecting by 2019, 1.7 to 2.1 million in covered California with subsidies. Those projections are likely to go down. And the reason they're likely to go down, we're working on new projections, we'll have something out fairly soon, but is covered California's premiums, for a variety of reasons, came in about 20% less than projected. So the subsidies under the Affordable Care Act are based on premiums not costing more than a certain percentage of your income. If premiums cost less, then there'll be more people who don't need the subsidy to reach those thresholds of the percentage of the income. And so the actual share of people we'd expect to get subsidies will be lower than our original projections just because premiums were cheaper. Then in terms of the overall uninsured, we are projecting in the end, 3 to 4 million people will remain uninsured in California. That's important when we look at issues like what's happening with the healthcare safety net system and the need to retain a safety net system. And it's important in thinking about, all right, who are these people who will remain uninsured and how can they be reached? A little over 1 million of them are likely to be people who are undocumented. Now, California has made some steps already. Unlike almost any other state, there are a few others who are doing this, but in California, a young adult who has deferred access for childhood arrivals, these are the dreamers, undocumented immigrants, but who arrived in the United States as children, nationally they're not eligible for Medicaid. But California's made the decision to do state-only Medicaid for that population, and paid for with state dollars. So in work done together with Claire Brundis here, we estimated there's about 125,000 Californians who fall into that category who could now get access to Medicaid. And there'll be a good big question about how many of them actually take it up. And that's one of the things we'll be wanting to look at. So in terms of monitoring this going forward, there's the question of what are the changes in source of coverage, and important, how does that vary by demographic groups? And really part of what we want to get to here is, what are the characteristics of those who are enrolled compared to those who have not enrolled, right? If we're looking at, are the enrollment systems working? Is the outreach to different populations working? One of the issues that's come up so far is enrollment of the Latino population has been lower than projected. And so that's led Covered California to develop in this last part of the enrollment period strategies to specifically go in and address the question of how to increase Latino enrollment, and that a lot of investment in outreach and advertising in that community. So it's going to be very important to understand who's enrolled, who's not, and why not, as much as we can, to be able to develop strategies to reach them. Another area that's important is changes in the type of coverage. So who's taking up the platinum, gold, silver, bronze plans, catastrophic plans in the exchange, and what's the difference by demographics? What do we know and help us predict in the future and understand insurance markets in terms of the population who are taking each of those up, both in terms of their demographics, but also in terms of their utilization patterns. And economic level. What we're seeing so far appears that most people getting subsidies are taking the silver plans, and people who are not getting subsidies, there's a higher level who are taking the higher end plans. What happens with employment-based coverage? This is an area where we're hearing a lot out there, right? All employers are going to drop coverage. No, they're not. They're going to increase coverage. We hear one of the big things we've seen so far, but again, it's hard to tell anecdotes from trends, is drops in some employers have announced they're dropping coverage for part-time workers. So, right, Walmart, Target, Trader Joe's have all said they're ending coverage for people under 30 hours, and some of them said they're raising compensation a little bit to make up for the difference. How broad is that? How widespread? Other things we've heard is employers, some of the lower wage employers, to get around the employer penalty, would be doing things like offering plans that cost workers up to 9% of their income. So under the law, they can't drop coverage, but they're not likely to take it up. And then that would keep those people from being able to get subsidies in the exchange, but would have the employers off the hook in terms of their cost. How much do they really do that? It's one of those things that's out there as a possibility. We don't know. To what degree will we see employers offering different kinds and levels of plans including skinnier plans? Again, something that we will have to see. Another area that we're very interested in looking at is the impacts on the labor market. One of the other big debates is when the employer mandate goes into effect, and it's been postponed for a year, is what happens to work hours, right? The employer requirement is only on firms with 30 workers or more. So there's been a lot of talk about employers are going to cut hours to go below 30. Our own analysis, looking at the literature, is we'll see some of that, but not as much as many are predicting, because it's very expensive generally to cut a full-time worker to below 30 hours because you have all these other attendant costs in terms of turnover, hiring, effects on productivity, et cetera. But if you've got a worker that's at 33 hours right now and you're not providing them health insurance, it's pretty easy to move to 29 to avoid health insurance. And so we estimate there's about 2.3 million workers who work a little bit over 30 hours a week and don't have health insurance. They're heavily concentrated in the restaurant and retail industries. That's a place to look. What is actually happening there? A lot of debate around the labor force participation in job lock. One of the CBO report came out recently talking about how the Affordable Care Act would reduce labor force participation. Some people were saying that's a disaster. Some people were saying it's positive. But the basic idea here is some people who are working just because they have health insurance may choose not to, may retire early. We'll see. What's the impact of the employer requirement on employment, as Will mentioned earlier? One of the barriers to self-employment and entrepreneurship is not being able to get health insurance. Will we see more self-employment after it's implemented? What happens to wages? If employers add coverage, will wages in those industries go down? If they drop coverage, will those wages in those industries go up to make up the difference? Economic theory would say it would. We'll have some ability to test that. So just to end on some key considerations. One is all changes need to be understood in the context of current trends. The share of people with job-based coverage has been dropping by about in the United States by about a percent point a year for the last 10 years. So when we look at what's happened, that gets us to the next point. Not everything happening is because of the Affordable Care Act. There's all these trends that are already happening in the market, and the tendency in this hyper-politicized moment is to try to pin everything on the Affordable Care Act. And again, it's important that things are understood in their context and evaluated in the context of the existing trends. The individual market is subject to tremendous churn, and this has a real important impact on how we think about sort of the numbers that are coming out. We estimate that of the people in covered California, of who's there in January, about 45% we would expect to be gone at the end of the year. Some people, the individual market sort of has two groups. There's some people who stay, about half of them are of course sort of stably there because they're self-employed or otherwise that's their source of coverage. And a lot of other people, it's where they go when they're between other things. You're in a job, you have job-based coverage, you lose the job, you're in the individual market for a period of time, you go back to job-based coverage. And so lots of people are going in and out. And so when we look at numbers that are how many people have enrolled over the course of 6 months or a year, that's a very different story than how many people are enrolled at any given point in time. And if we want to understand overall changes, it's important to be able to look at those snapshots and say not just, here's how many people have enrolled since October, but what is how many people were in coverage in October and how many people are in certain types of coverage today, and so what's that net change? To give you an example, if you look in the material from the Department of Healthcare Services, in terms of Medi-Cal, it's about the change from October to January was about 800,000. A lot more people enrolled, but you have people disenrolling at the same time other people are enrolling. So that net is important. Here's a key thing, though. We won't know the answers to these questions for a period of time. So I know everybody wants it now, but for Medicaid, we have good data because the Department of Healthcare Services puts it out. For the individual market, we'll have some data from the Department of Insurance and the Department of Managed Healthcare, but probably not till later in the year. To really understand what's happening with uninsurance, which is something everyone cares about, current population survey for this March current population survey will be out in the fall. but it's done, where they ask healthcare is every year in March. And we're still in the middle of open enrollment. We're towards the end, but it won't be a complete picture. So the first good picture we'll have will be somewhere around September, but it won't be complete. California Health Interview Survey, a great source, will know more probably about a year from now, a little bit more. And so I think just to end, the key point here is we're going to have to all be patient. There's a lot that we need to look at. It'll take time for real numbers to come out, and it'll take time to really understand what they mean to do the kinds of comparisons Will was talking about. And in a world where everybody wants to look at this in a political context, it's harder to take that time, but it's really necessary to step back and look at it if we really want to understand what's happening. Thank you.
Thank you, Ken. That was setting out a series of questions that are like the first chapter of a mystery book, and then telling us that we're going to have to wait for the 5th sequel to get the answers. So we'll be staying tuned. Our final speaker is Claire Brindis, who is a friend for a long time and a friend of many for a long time, Director of Health Policy Studies here at UCSF. Claire.
Well, it gives me great pleasure to be here, and I too want to thank Ed Yellen and Janet Kaufman for having done a stupendous job in this series, and also really grateful to all of you for having come on these precious Thursday nights to become even a better informed population. And it's really wonderful for me to be with my colleagues on this panel. So I'm going to be taking you a little bit into a different perspective. And I decided to use the word or the theme of kaleidoscope because you've been hearing a lot about very large issues, both from Ken and Will, about coverage and coverage issues and employment issues. And I want to sort of bring the conversation to this issue of the fact that the complexity of this whole topic is this is the symbol in Chinese language for the word change. So it's both danger and opportunity. And as someone who's very interested in the area of adolescents and young adults and women, what I wanted to do is bring down or bring to the focus a slightly different perspective in terms of what are some of the opportunities to learn more about how does healthcare impact the health status and health and well-being of very vulnerable populations in our society, and what is the role of health insurance coverage, and how do we go beyond the numbers of saying, oh, we've been very successful in enrolling millions of people, to what actually happens after you get that license to go shopping for healthcare. And Marianne did a beautiful job in demonstrating and showing to you in the framework that the foundation has developed, all those various layers. It's almost like a Russian nested doll concept. That now I want to take you a little bit more into how, as an evaluator who's been very interested in these topics, start to think about where are some areas and what sources of data would I want to use to begin to answer some of these questions about did the ACA actually make a difference? So one of the things that this little cartoon shows you, the old system was simpler on the right, which is no admittance, to the very complex pathway on the left of Covered California Health Benefit Exchange, is that I think we all need to remember that part of the reason that ACA was brought in was the immorality of having 50 million Americans without health care coverage. But we also have to acknowledge that even before the ACA, when we had programs like Medicaid or the state children's health insurance program, there have been many solidly good insurance programs out there and many, many years where we did not have the enrollment of those individuals who really could benefit from enrollment. And there have been numerous studies to understand the barriers to health insurance coverage, particularly a topic that Ken mentioned that I've been very interested in, having to do with undocumented, the families who perhaps, for example, have one child who was born in this country and one child who was born in Mexico, and feeling the Sophie's choice of whether or not I should enroll in a program like Medicaid when one of my children can get access and one of my children cannot. So we need to recognize that we've had a really, really complex system long before the ACA, and this is a point that all three of our former speakers on this panel have already raised to you. But when it comes to young people, I think it's really important to be thinking about what are the opportunities that we have to impact this population. We know that one of the successful components of the ACA was the fact that the expansion of up to age 26 on parents' insurance plan, which of course this is more middle-class families that already have insurance, but it was very clever in terms of the ACA targeting a middle-class population and having coverage to expand up to age 26. So a question as an evaluator, as I start to think about this, is what are different kinds of metrics? So we now know that over 3 million young Americans are now enrolled into their parents' health insurance program. But we still don't know very much, and I will share with you in a few slides a little bit of preliminary data on how those young people are using the health insurance program. But as I'm conducting a variety of interviews and focus groups with young people, particularly related to an Institute of Medicine study that we're doing on young adult health, I'm learning about all the various barriers to healthcare coverage. And one of them that we will be tracking over time is the issue of explanation of benefits, EOBs. So when you come in and get a service, it's a requirement that the person who is the policy holder gets a notification that someone came in and used your insurance plan. And how that is a tension point with the whole issue of confidentiality of health resource utilization, whether it's in the area of mental health, substance use, reproductive health. And one of the elements that we've been tracking at a variety of states is what are some of the innovative ways that we can continue to be sure that an explanation of benefit is sent appropriately, because that is sort of a means to prevent having any kind of a challenge of inappropriate use of a health insurance benefit, while at the same time, for someone who's even 22, 23, 24, who may not want to tell their parent that they went in for a reproductive health visit. So there are a number of issues and complexities and nuances that even when we have a license to go shopping, doesn't mean necessarily that the whole healthcare delivery is set up in a way that can be responsive to the needs of these young adults that are representing the future generation. And it's been very interesting to me as an evaluator. I use a variety of methods, both quantitative and qualitative. And one of my qualitative methods is something that I call windshield anthropology. So windshield anthropology is really looking for indicators that tell you that there's something bubbling up, that begin to give you sort of the smoke detector that there's something that's interesting. And I was very struck because of this big pressure to get young people enrolled in health insurance coverage, right? They're the healthy lives. We want to get more of them into the health insurance programs. And clearly by March 31st, that when the president of the United States goes on a show like Zach Galifianakis is Between Two Ferns, I might have mispronounced his name. I apologize to anyone with Greek background. But here was a humor site called funnydie.com, which became the #1 resource of referrals to healthcare.gov. So the fact that this is happening is a little bit like a Twitter kind of approach to tell us that there's something going on to the fact of really thinking about how do we get these young people enrolled. So part of the reason that I'm harping on young adults and adolescents is because this is a very critical period to prevent chronic conditions of adulthood. And if we think about some of the information that Will was raising about where does our healthcare costs come from, we know that non-communicable diseases, such as those related to obesity, such as those related to heart disease and cancer, which are preventable in many regards, do begin in many respects during this age period. So investing in this age period is very important because not only does it represent a window of opportunity, but it also represents an important window for transitioning into the adult healthcare system. And from previous quantitative evaluations, we know that while about 15% of all the US citizens and residents lacked health insurance, and not all citizens, that about a third of this age population did not have health insurance coverage in the past, and that we know that very little professional attention has been devoted to them, and that even though there are clinical guidelines for prevention, we need to know what the content of care is. So this is part of those evaluation issues that I want to explore further. Another important issue is, where do these young people live? As you have heard in multiple of these panels, it will matter very much where these young people live and whether they live in a state like California that is expanding Medicaid as compared to those states that are not. So are we eventually going to use quantitative data and other kinds of data to look at what difference did it make in which state did you live? Another issue really has to do with the essential health benefits. And so a major set of evaluation questions would be, did the young people and women that I'll touch on briefly later get access to all those benefits? So I had the pleasure of working on the IOM panel that made the recommendations around women's preventive services without copayment. And as many of you may know, those 8 recommendations were adopted by the federal government as part of the ACA. So a real question is, will women have access to reproductive health services and all the FDA-approved methods of contraception without copayment? But furthermore, if a woman comes in for a preventive service, yes, a preventive visit, she should be able to get those 8 preventive services. But what happens if she comes in because she had the flu or she had some other health condition and at the same time tries to get the preventive health service? Will the insurance carrier give her that service without a copayment, or will that come under the auspices of it being a clinical visit? So this is part of my mosaic, or the kaleidoscope, just to give you a sense about the fact that as we look at these evaluation questions that I'm very lightly touching on, that I will be relying a lot on a variety of national health survey data, whether it's the health interview survey data or the medical expenditure panel survey, or the CHIS data that's been mentioned, which is the California Health Interview Survey data. Now, all those data sets are important, they're complex, and a big question as an evaluator looking at these national data sets is, are they asking the right set of questions? Are these questions adapted to what the ACA is attempting to accomplish? Who is answering the survey? And how long will it take me to get the answers that the American public wants to know? So for example, in the area of mental health needs, knowing how many young people actually received mental health services the last time they went into care is extremely important, because we know that 1 out of 5 young adults between the ages of 18 to 25 experience mental health disorders, and that they have very high rates of psychological distress, suicidal thoughts, and very high risk of risk behaviors. Well, our national data already tells us that only about 2.5 of young people who needed substance abuse treatment services were able to get them in the timeliness that they really wanted. It's not just, are these services available, but were they made available to you when you needed them? Or that only about half of them, of these young people, are receiving routine health services and preventive care, where some of the screening around these services would be available. The area of mental health, I just do want to mention that when I have been very impressed by the fact that a new study from the Employee Benefit Research Institute, which is one of the first studies to look at how these young adults use the healthcare system, these expanded up to age 26, it turned out that not only was there an increase in the use of services, that makes total sense, but that 42% of all the inpatient claims were used for mental health and substance abuse services after 1 year of coverage. Clearly, there's been a dearth of mental health parity in the availability of resources for a lot of these young people. So in terms of qualitative methods, one of the issues that we want to be studying by interviewing young people, by having focus groups, is, are we closing the knowledge gap? Earlier studies showed that about 71% of the uninsured knew about the new options related to insurance, or knew that they would have a variety of options. But now we need to know how these different strategies that Marianne was talking about, are they helping to close the gap? What sources of information do young people need, and do they trust, and will they make themselves available to use? And this is also looking at things like what kind of language do these young people use, and also whether they use the healthcare finder and the apps that help them to find the kinds of doctors in their own communities, and whether they can really define and understand the health insurance benefits that they qualify for. And I think an important source of data for our evaluations are the moms, because it's the moms who are really becoming a very important factor into whether their young adults are actually enrolling. And this is not just about expanding into the age 26 for those who have insurance coverage already, but moms of low-income moms who are also becoming the source for having the young people enroll. I want to very briefly, because I have 1 minute, to talk a little bit about women's health evaluation. And that is work that Alina had mentioned to you a couple of weeks ago. There were many insurance reforms that occurred before the ACA, but clearly after the ACA, we have many conditions that affect women. For example, no exclusion of pre-existing condition, or that gender is not going to determine premiums. All of these questions are up for debate. All of these questions are up for evaluation and for tracking and for monitoring. And we have to look very carefully at this role of preventive health services, because if there is something that's very important about the ACA is it's really trying to change our mindset about moving into prevention and not just tertiary and quaternary care. So a lot of these questions are, did the dream of these preventive services, where's there access to these to the services? What happened as a result of the access? And who got the services and who didn't, and why? And what can we do about it to improve it? So to finalize, there are lots of questions. I'm really excited about living in this time as an evaluator, and stay tuned and be patient.
The question has to do with peer review, and are there other countries that can provide us any model of how to more effectively use peer review for ACA?
So as Ken was just saying, and I'll sort of, it's the same thing that I was thinking, that in terms of countries that do not have a single payer, but have very high rates of insurance coverage, when they have multiple private insurance companies individuals are choosing to purchase insurance from, the Netherlands, Germany, Switzerland are countries that have relatively similar systems, although they do have much stronger government oversight and mechanisms for trying to regulate the systems. And so understanding how those oversight and regulatory mechanisms are working within a system that we are moving towards, I think is something that we need to continue to do.
I just want to add one comment, and that is when Medicaid and Medicare were introduced in this country, there was also very few states that signed up, and it took a very long time to get those programs launched and studied and implemented. And we're still studying and implementing many components. So, apart from the international comparison, I think we can look at our own country's history.
The question has to do with the way that changes about healthcare reform and the evaluation of them are communicated to the public, and what happens once it's out there and subject to a lot of political winds. With the analogy of climate change being part of being something that scientists know is occurring, but the public at large doubts that it's occurring, how does health reform save itself from having the same kind of fate? And the question was directed to me, thank you very much. And I guess what I'd say is that in my opening remarks, the analogy of these are going to be these will be our finest hours, that speech was made by Winston Churchill before the Battle of England, before even the Battle of France. and was really rallying the troops, and the troops include you, not just scientists, rallying the troops and the population in order to be aware of and ready for the battle of their lives. And for health services reform, this may be the battle of our lives, as well as the best years. So I guess that's what I'd say, is to be prepared for a series of years in which communication is going to be very important. And on a kind of step-down note, I'd say that the capacity for scientists to be able to speak a language that regular people speak and to be able to translate scientific findings into the vernacular is extraordinarily important, never so important, always a challenge, never so important, and fortunately there are some organizations that are really dedicated to doing that.
I'll get there. So I don't find the comparison especially compelling in that the whole idea of health reform is premised on shared cost and shared responsibility. So in that regard, I guess it is a little bit like climate change, and maybe the flaw that we all have in understanding and communicating is being able to say that and accept it, and be grown up enough to say we all have a responsibility and we all should share the cost. We struggle with that. In other regards, though, the cost structure, the complexity, this is a big, messy, yucky business and political problem. Climate change is in a different way, and I'm not an expert, so I won't say, but one reason it's interesting and important to track and communicate is because, to me, it's not black and white. And so, with all kinds of respect for people here who may believe that this is the greatest policy ever, it's pretty messy, and it's got some ugly sides, and it will have some unintended consequences. So to me, it's much more important to watch it and report on it, and again, keep your eyes on the big prize, than it is to be an evangelist for something that, is a little messy. So. But now we can...
I was just going to add that some of this really will play out with people's experience. People have all sorts of concerns, hopes, dreams, and as they go out and go into the market and get insurance and use it, there'll be people who thought it wasn't going to work, and will find, yes, they're getting these subsidies they didn't expect, and it's working well. And there are going to be other people who were backers, big supporters, went in and found out that they can't get their doctor in their network, or they forgot to report a change in their income over the course of the year, and then when they file their taxes, owe a bunch of money back on their subsidies, who will then, have some kind of shock and say, hey, wait a minute, maybe this didn't work as well as I thought. I think this is going to play out, which means for people who think the law was a good thing, probably one of the most important things is doing the work to make sure the implementation is done as smoothly as possible, and that people really understand the law and how it works, because it is complex. The other thing I think it is, all this research is very important so people do understand what those impacts are, and I think we do see lots of things being thrown out there that really have little relationship to the Affordable Care Act. But in the end, I think translating that into the language people can understand, but also finding who the right people are to deliver those messages, who are talking to the communities. I'm lucky in my job that I've spent a lot of time over the last few years going out to union audiences and talking to members about the Affordable Care Act, and my experience is people are really hungry for good information. They don't feel like they have access to it, they don't feel like they're getting it, and so that combination of their own experience and figuring out ways to really reach people where they are.
I'll do one more PS, which is a shout out for consumers and consumer engagement, because I think that the whole issue of death panels that happened early in the debates about the ACA would have not happened if we didn't have consumer voices at the table. And I've been very excited about some of the innovations about getting consumer engagement in the, sort of system redesign experiments that are taking place, and really hearing the voices of consumers as partners to healthcare providers, as well as partners to ourselves as researchers. So getting community participation in doing program evaluation and having those consumers well informed and being the spokespeople is part of the solution.
Two-part question. The first is, how are consumers being engaged in the conversation about the pricing of health insurance? The second part of the question has to do with people who lost their health insurance and what kind of tracking is occurring for that portion of the population.
So I'll take on the first question to start with around premium setting. So again, as we think about some other countries, the government typically has a much stronger role in regulating premiums around health insurance. In California, Covered California, the exchange has taken an active purchasing role in that they are proactively negotiating with health insurance companies on behalf of consumers in order to try to keep the premiums at a reasonable rate. In addition, in some states, the insurance commissioner, the equivalent of the Department of Insurance, some regulator, has the ability to reject proposed premiums which are too high. There has been a debate in California over the last several years, and it is ongoing, whether in California regulators should be given that authority as well. So currently, the state regulators do not have the authority to regulate this. How you would actually bring in individual consumers into this process, I don't know any place that has an effective mechanism for doing that, but we have representatives of consumers who are attempting to play that role. Now, when you have a different administration in place that may have a different perception of their role in defending consumers versus defending businesses, then the regulators sometimes play a different role, and that is sort of one of the really difficult challenges that we have in our society overall. Does someone else want to take on the second question? Yeah.
Okay, so I think you're talking about, with the second part of the question, the people who received cancellation notices for their existing individual insurance policies. And that number that you cited is probably the national number. That's certainly larger than the number in California. And I don't know the number offhand. So the idea here is that under the law, as it was originally envisioned, with the establishment of these new essential health benefits with new risk pooling in 2014, there was a natural end point to existing individual insurance policies that were not in compliance with all of the requirements of the law, and they would be replaced in 2014. When the cancellation notices came out, there was a big furor about that. There was a big pushback because President Obama said not once but tens of times, if you like what you have, you can keep it. Turns out that was not well messaged in terms of what was actually written in the law, so there have been extensions and changes as a result. Those have largely not taken effect in California because of some of the contracting rules and requirements that Covered California put in place, and the legislation that California enacted to enable the law that was much more intentional about saying, in California, we will move more quickly to the new risk pooling and benefit requirements of the Affordable Care Act. And for me, what was absent in that whole conversation was, it's not just if you like what you have in terms of benefits, you can keep it. It was if you like who you're rated with, you can't keep it. And that's what was the big issue around the premium increases. Now, how many of those people have now moved to a different coverage or have gone uninsured? We don't know that yet. We're working hard to try and obtain data sooner than the year and a half it would take to get that, and I hope that maybe by summer there will be some movement, so we'll have some idea of how many people are in the individual market, both inside and outside the exchange. And I think it'll be interesting to know at that point whether in the aggregate we've seen, a decrease, which is what the worst fears would suggest, and a large increase or something, that's more modest. So we'll see.
you.